Hi, good morning. I think we should start now. My name is Ika Novianti, the Regional Coordinator of Youth Lead, also a member of the Seven Alliance. So today is our second day of the webinar for the Learning Hub. So we would like to welcome you to today's webinar on Malaria Community Initiative in the Asia Pacific region. Before we start, perhaps you can introduce yourself in the chat box, including your organization and country where you work. You can also rename yourself to include your pronunciation so that we can pronounce your name correctly. So yeah, malaria remains a significant public health concern in Asia and the Pacific. Despite substantial progress in the recent years, the region faced unique challenges, including the emergence of artemisinin-resistant malaria parasite in the greater Mekong subregion, which threaten global malaria control efforts. In today's session, we intend to inform the Asia-Pacific region, civil society, and also community representative about malaria community initiative, CLM in malaria, community engagement in malaria through the webinar. We will provide details or information on the initiative of the malaria community, the major technical assistance needs for the community, and how community-led monitoring in malaria is taking place in the greater Mekong sub-region. So before we start, and before I forget about this, let's have a group picture. Please open your camera and then we can take like 1 or 2 shots and we can start to the discussion. Okay. Comms team, please help me to do this. Let me enter. Okay. Ready? 1, 2. Cheers. All right. Thank you so much. Davi, Leo, did you take the picture? You managed, I managed to take like two shots. All right, then. Without further ado, I would like to give the mic to Sri Hasri to give like opening remarks and one to couple of things about the malaria in the region. Sri, over to you.
Good morning. Thank you, Ika, for giving this floor. Can you hear me?
Yes, loud and clear.
Okay, good. Well, nothing much to say. You started very well, laying out malaria situation in the Mekong. So just I wanted to start with little bit information about the CSO platform which we are working with in the Mekong region. Let me share my slide. Okay. So my name is Srihari Acharya. I work for CSO platform, which is hosted by Alight here in Bangkok, and we are under the Global Fund Regional Artemisinin Initiative 4 grant, which is also known as the RIFE-4E in the Mekong country. And the platform was established in 2014 with very simple objective to and only one objective, to share information and knowledge on SPCC along the Thailand and neighboring countries border area, targeting improving service to migrant population. And later it was expanded to a broader area. We started with about 10, 12 NGOs partnership. Now we are network of more than 60 community-based organization or NGO, INGO, and global level INGOs network. We are also the constituency, community and civil society constituency for Global Fund RAI RSC, which is equivalent to CCM. You have seen on flyer, Professor Maxine is one of that representative representing CSO platform literacy. Will speak about the some of situation and also the work we are doing in detail. Under this round of funding, we have 4 main objectives for the platform. The first objective is we're aiming towards elimination, so to advocate for continued resourcing and technically sound approaches for the achievement and the maintenance of malaria-free GMS, because there are a couple of examples that even if we get zero malaria, if we are not well prepared, it can come back again. The second is equity, and to support improve inclusiveness of and equitable access to health services. Third objective is effectiveness, to share knowledge of the best practices and the challenges within the region and also outside the region. And engagement, I think the part of engagement that's been the heart of platform work, because this is the main source of information and data we get from the community and civil society, but also very powerful tools for us to do advocacy at the country, regional, and global level, including Global Fund. And the reason we are here today, because the 7 Alliance, this learning hub, community learning hubs objective, and the CSO platforms objectives, you can see somehow it's aligned in this sharing in knowledge and information, and also providing technical support. So couple of months ago, we agreed to work in partnership, and then this is the first activity we are having today. For the platform, I'm trying to give you some broader overview of the activity. So later you can also see where your work fit to this, and you can connect with us either directly sending us some of your information or through 7 Alliance. So we organize regular consultation and knowledge sharing activity in the region and global level. We provide capacity strengthening support that includes the technical support through the training and the tools. Sometimes we connect our partner to different other TA providers. And then this is, again, why we are here. And third one is country partner and community engagement for the data and advocacy, which I already spoke. Fourth one is implementation of the community-led monitoring and GESI. Professor Maxine will talk about this later. And the PSEAH advocacy and awareness raising activity. This is new to community level, but we are trying to initiate this awareness at the community, because there was a different phase approach. In first phase, the donor was approaching implementation level, which is NGO. And then second phase, now they're approaching the government implementation level. And we are parallelly helping raising this awareness at the community level. So with this, I welcome all of you to this webinar, and I hope you will find it useful, informative. And then I welcome you also to participate in question and answer, so we know what are the needs we need to prepare and how we can work in partnership to eliminate malaria from the region. That's all. Over to you, Ika. Thank you.
Thank you so much for your welcoming remarks and the information. So as Sri mentioned, if you have any question, please feel free to address it in the chat box. So we will have another minutes to answer your question. So now I will give the mic to Chinmay Kumar, the coordinator of the Learning Hub, to introduce the Asia Pacific Learning Hub and also Seven Alliance Consortium. Chinmay, over to you.
Thank you so much, Ika. First of all, thank you so much everyone for joining. Um, yeah, so um, as we are very excited to talk about malaria community initiatives, best practices, and we wanted to identify technical assistance need in the Asia Pacific region through Asia Pacific Regional Learning Hub. First, I would like to introduce the Seven Alliance Consortium. So, Seven Alliance Consortium is a representative body for communities in all our diversities, mainly affected by HIV/AIDS across the region. The consortium also tries to gain expertise with tuberculosis and malaria community by sharing knowledge, resources, and information. Our goal is to establish stronger and sustainable mechanisms for key populations and people living with HIV throughout all the three diseases. Mainly the organizations who are part of the consortium are the regional networks with a wide variety of expertise, mainly from HIV/AIDS, but also, as I mentioned, we are exploring and broadening our boundaries with tuberculosis and malaria through Asia Pacific Regional Learning Hub project. The organizations um, are APCOM, Asia Pacific APN Plus. Then we have APNSW, APTN, ICWAP, NAPUD, and Youth Lead, where our major focus area, and we say the pillar of the Seven Lines Consortium is cross learning and innovations, collaboration and partnerships, and research and strengthening. Um, so if you want to know more about Seven Alliance Consortium, you can reach out to us through our website. We also have email ID where you can directly email us for any information or questions you have, and also follow us on social media pages, which will give you our daily updates from our side. Um, as I mentioned, the Asia Pacific Regional Learning Hub is the project funded by Global Fund, and it's hosted by Seven Alliance Consortium. The Learning Hub is a vibrant space the for the communities from the Asia Pacific region to share peer exchanges, capacity building, collaborating on different levels for the community engagement and strengthening of the community and leadership of the communities most affected by the three diseases, which is HIV, tuberculosis, and malaria. Um, our main role is to identify needs from different countries in the Asia Pacific region, where we can highlight it and make sure the high priority issues are well informed and voiced out in the global fund processes in the country level. Apart from that, we also disseminate newsletters every month, which will showcase our work at the regional level, and also um, keep the communities informed about the progress and the changes happening in the region as well as globally. Then we have a very important a component here, which is technical assistance component. So technical assistance component is basically a global fund short-term technical assistance, where this opportunity is for everyone who is implementing global fund processes in the country. I want to also put a bit phrase here because this is a grant opportunity. It's a short-term grant opportunity, but like Asia Pacific region um, does not utilize this at all. And that is why also we are having this webinar hoping to identify needs from the malaria community. So we can brainstorm more and talk about the issues through short-term technical assistance. Then we have rapid engagement support, which will be in form of small grants, where we will be putting this more into our newsletters and our websites once we progress towards this work plan. And the last one is highlighting case studies and good practices from different countries into the region, and making sure that these good practices are replicated by the other countries as well, to to get closer to our goal of ending AIDS by 2030. um yeah. So as I mentioned, these were the work plan which I just mentioned, but this is how you can connect with us, um, for joining hands in making progress, um, during the work which we do. So first is, we will request you to subscribe our newsletters and the social media pages, because we share all the opportunities as well as latest information. Also, we are always available if for the call, if we want to brainstorm more about short-term technical assistance grant through Global Fund. We also make sure that we participate and request communities to participate through virtual as well as in-person learning events. And this is also one of the reason for communities to connect with us, so that we can have more and more collaborations in the future. And we are also going to support scientific events and sessions which will be taking place in person. So if we have good collaboration opportunities, we can definitely support communities to participate in those platforms, and apply for small grants. So again, this is one of the reason to get connected with us, so that we can give you updates on the opportunities. So this is the overall work plan for from 2024 to 2026, where we already implemented the survey, and right now we are hoping to identify high priority needs in the countries. Apart from that, we have virtual learning session. This is our second virtual learning session right now happening, and we will be conducting more during the end of the year. Then we have newsletters every month. Then we have technical assistant requests to talk about and country engagements as well as scientific events and case studies. So this is what our overall work plan of Asia Pacific Regional Learning Hub looks like. And it is not possible without communities. It is not possible without by just focusing on HIV. And we are hoping and we are very much positive to also get support from tuberculosis and malaria community at the same time, to um, to to make sure that we are covering everything in this region. Yeah, thank you. Ika, over to you.
Thank you so much, Chinmay, for the comprehensive information about the Learning Hub and also the Seven Alliance. If anyone have a question for the Learning Hub, please feel free to ask your question or just unmute yourself. Stephen? Oh, okay, sorry. If there is no, maybe you mentioned, but so there is one question in the chat box. You mentioned about the activity about the for the consortium. Is the activity of the consortium limited to Global Fund countries or project? Harry or Chinmay, do you want to answer this question?
Thank you so much for the question. I'll just try my best to answer, but Harry can join back. So no, the project is of course hosted by Seven Alliance Consortium, but the Seven Alliance Consortium is not only focusing on the project related activities. Apart from that, Seven Alliance Consortium is also um, 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 very much active in implementing community-led monitoring initiatives, and um, also making sure that the voices are heard at the different platforms. Harry, can you please share anything which I'm missing?
Yes, so it's basically Seven Alliance Consortium is a movement. Movement we created among seven regional PHIV and key population network in Asia Pacific. So we think that we believe the community response is crucial in terms of the global response on 3 diseases. So we started our movement on CLM. Now we start to move again, movement working together to bring TB, malaria, and HIV to work together and learning together on each other diseases, on each other responses, and then we're coming up with other things like gender transformative or something that we really think that is going to be benefited to community in the regions. That's about Seven Alliance, but we're still remaining our own work though. Go back to Ika. Thank you.
Thanks, Harry and Chinmay. Yeah, I just want to iterate what the Harry and Chinmay saying. The Seven Alliance Consortium is not limited to the Global Fund. However, the Learning Hub and also the technical assistant will only limited to the Global Fund project. So if there is no other question, then we will watch a clip because Annabelle from the Global Fund, she unfortunately can join us today. So we will hearing the video on the technical assistant. Okay, yeah, we can play the video. We cannot hear the voice, sorry.
While we are setting up that, I saw a message asking translation support. Do we have AI translation in Zoom?
Let me try to. I don't think we have the translation for now.
So to Ewin, we have to say sorry.
Yeah, we are apologize that we couldn't help with the translation, but we will make sure that in the future we will have the translation mode for the webinar.
Thanks so much for the opportunity to brief you on the short-term technical assistance that is available under the Community Engagement Strategic Initiative. And you will receive the slides from the Seven Alliance team after this call today. Just in terms of the objective of the SI, many of you are aware that the focus is really on strengthening leadership and engagement of communities most affected by HIV, TB, and malaria in Global Fund and related national processes. And it's really important for us to reiterate the focus on national processes because this is also the focus of the TA mainly. So I will mainly focus on the first component of the SI, the short-term peer-to-peer technical assistance. But just to show you again, like the overall outcomes of the initiative that the TA will also contribute to, which is really around communities generating and using data to inform advocacy and decision-making, communities having capacity to mobilize and hold their representatives and decision makers accountable. So these are really the main objectives that the TA is contributing to. We have updated our pool of short-term technical assistance providers. In the previous cycle, we were working with 26 short-term TA providers, and now the pool is a little bit smaller. We have pre-qualified 19 TA providers for this 3-year cycle, and we have all set up a contract with them, and several of these TA providers are readily available to provide short-term technical assistance in Asia Pacific region. And we're particularly happy also to see some more TA providers from community-led networks and organizations. In terms of past overview of TA, I just copied this from our last evaluation of the GC6 strategic initiative, and it gives you a perspective on the number of assignments that we delivered by region. And you see that in some regions, there was quite a high number of requests and assignments, such as the Latin America region or ICA region, and it's also partly due to limited other TA mechanisms that can provide support in these regions. We provided in the previous cycle 5 assignments to high impact Asian countries and 7 assignments to Southern and Eastern Asia countries. So 12 assignments in total out of 130 34 assignments. So you see that there's definitely opportunity to mobilize a higher number of TAs in this 3-year cycle. And we're very grateful to be able to work together with 7 Alliance and some of you to mobilize the support. Just to recap what the short-term TA is there for, it's very similar to the previous cycle, and some of you know the TA menu already. We can support rapid CRG-related situational analysis or needs assessment. For instance, this could mean analyzing CRG-related barriers to HIV, TB, or malaria services. We can support engagement throughout the country dialogue and the grant life cycle. This includes engagement in funding request development and grant making, but also in NSP review and development. And we can also support engagement in program design. For instance, we had some cases where there was budget set aside in the Global Fund grant, for instance, for HIV prevention programming for the transgender people, but it wasn't really clear how the package of intervention should look like. So we helped with doing a consultation to actually inform the design of these programs. I want to highlight that some areas are not eligible, which include CCM strengthening, which includes long-term capacity development of civil society networks and organizations, everything related to development of strategic plans, organizational strategies, manuals, and so on. We can unfortunately not support, but other mechanisms can. And we can support consultants to do the actual funding request writing. Overall, we will be able to support around 4 to 6 TAs per region per year. At the moment, we have a TA assignment ongoing in Solomon Islands. In terms of how the support looks like, we can mobilize experts for around 30 days who will implement in a period of 3 months. And we aim to work as much as possible with experts from the country and region of assignment. In terms of the process and how it works, we have 5 steps. At the application stage, we really work closely together with the Learning Hub, and you can bring us also into initial discussions. If you have identified a need regarding community engagement, then your task would be to complete the TA request form, which you can find on the Global Fund website, the community engagement page. You would complete it. There is a requirement for the Learning Hub to review it, and then you would need to submit it to this email address, ceta@theglobalfund.org. Afterwards, on Global Fund side, we will review the request for eligibility. This involves the CRG team, but also colleagues from the Grant Management Division. And if the request is eligible, we will provide you feedback and move to the mobilization of experts. This step includes development of detailed terms of reference and a budget, identification of experts who are available and qualified to deliver the TA. And then we are hiring these experts and move into implementation. We usually have a joint kickoff call with the consultants, with the TA requester, and then basically the TA requester leads implementation and finalization of deliverables. What is important for us here is that the consultants work very closely with you as TA requesters, and that the deliverables really respond in terms of the content and the format to what you need. For instance, we usually don't ask for specific TA reports, but the deliverable can either be a report, a consultation report that you can use. It can also be a presentation. It can also have some other format. So for us, it's really important to align with what is most useful for you to use in the advocacy locally and regionally. And then afterwards, we have newly introduced that the Learning Hub will do post-assignment interview with the requester to capture some of the learnings from the TA and feed it back into the regional learning. I just want to reiterate one thing in terms of timeline. For us, it takes around 3 months to mobilize experts, which really means that if you have identified a need for engagement or an opportunity, kindly request the TA as soon as you know, because it's very difficult if we receive requests, let's say today, to engage in the HIV NSP revision due to happen in 3 weeks, then it's really difficult for us to mobilize. And most of the time we will not be able to mobilize expertise. So it's good to really plan a little bit ahead, a couple of months, think about 2024, what are the key processes that you want to inform 2025, and really request the support as early as possible. Just a recap of some of the changes to the TA component in this cycle. We have a slightly reduced budget in the SI overall from 16 to 14 million, which has implication on the number of TAs we can deliver. As I mentioned, we have an updated pool of TA providers, and we have updated all guidance material on the community engagement page of the Global Fund, which includes the TA request form. We have a TA guidance note that you can look at. It includes a lot of very practical examples on how the TA looked like and to get a better idea of what is actually eligible. And we also have the list of TA providers that I showed you earlier online on the Global Fund website. So you can see which TA providers have expertise to deliver in the Asia Pacific region. And just important for those of you who requested TA in the past, that we have changed the email address. So please use, instead of using CRGTA, please use CETA in the future. And with that, I'm handing over to Ika, and I'm available to respond to questions if there are any.
Yes, there's the technical assistant video and also explanation. If you have any question, though we don't have Annabelle here, but we have Chinmay, who will be available to answer the question. Okay, I will take silent as no question, but please feel free to take to add your question in the chat box if you have any, so that we can answer those questions once again. So let's move to the other session. So we will have Professor Maxine Whittaker to sharing about the Malaria Community Initiative and also the best practices. Maxine, over to you.
Thank you very much, Ika, and thank you everybody for joining today. I want to make sure there's some time for questions and comments, so I'll get moving. These were the objectives, as has already been talked about for the session, this whole session, so I won't reiterate those. Just briefly, what's the situation of malaria in the Greater Mekong sub-region? From an epidemiological point of view, first I just wanted to put the definitions for malaria around control, elimination, and eradication. It's different for various infectious diseases. For malaria control, it's trying to reduce disease incidence, prevalence, and morbidity. So how much of it's around, how many people get sick and how many people die, to a locally acceptable level as a result of deliberate efforts. And to sustain control, you need to continue to do interventions. What the Greater Mekong sub-region is trying to do is malaria elimination. And for malaria, that's defined as the interruption of all local transmission of specified human-to-human malaria parasite species in a defined geographic region, again, as a result of deliberate efforts. So to get rid of all the local transmission in a country, and then we hope in the whole region. Eradication has got a different meaning in malaria, and it means basically that there is no malaria anywhere in the world, and there are no cases anywhere in the world. So basically, malaria is here to stay until it's over everywhere. And that's what the global initiative is trying for. We're trying for elimination as a step towards that. You don't need to look at the detail in these maps, but basically look at the colours. And I apologise to anybody who is colourblind and unable to see these colours. The map on the left-hand side, as you're looking at it, is for falciparum malaria, where there's mainly blue. And you see that there's very few places now that have malaria, falciparum malaria, the common one in most countries. You can see it's mainly in the border areas of the Greater Mekong subregion and a little bit up in Vietnam in the middle there. In the green, that's P. vivax, the other malaria, which there's more of. You eliminate P. falciparum and you now start seeing P. vivax, which is what we've got in the Greater Mekong. But again, you see it's still in those border areas. The darker the colour, the more of that malaria there is. These graphs, again, right-hand side is P. vivax, left-hand side is P. falciparum. And again, you see over the 3 years that it's decreased in most of the countries, Cambodia, Laos, and Vietnam. However, what you're seeing now for the black line in Myanmar and Thailand is we're starting to get the malaria cases increasing. In Myanmar, because of the complicated situations that are occurring there that are preventing services to the majority of the people, and a lot of people are mobile. In Thailand, it's along the borders with Myanmar where people are coming into Thailand, and we are now getting reintroduction of malaria into some provinces where it was previously eliminated. Shri mentioned that earlier about trying to sustain the elimination. So how about the people and the providers? So in the Greater Mekong subregion now, these are the types of places and people who get malaria. So people working in forested areas, people who are rubber tappers or working in plantations of various kinds where there's lots of trees, people who might be mobile working in there collecting forest products of various kinds, and then the villagers who live on the fringes of those forested areas or live in those areas, and a lot of ethnic populations, again, who are often in those border and forested areas, and logging, but also in many of the cases, the military. So anyone who works in those border areas. And a lot of these are predominantly men, but there are women and children who travel with these men into the forest areas. Many women themselves collect forest products as well as a main or supplement to their income. This graph shows you the blue is what comes from the public sector for tests confirmed cases. The community sector is the orange and private sector is the grey. And again, you'll see in many countries, the orange is a large percentage of how people in those countries get confirmed as having malaria and get testing and treating. In some countries where it's a lot more blue, often that's two things. One, it's that although they're tested by community-based workers, they have to go for treatment, particularly for P. vivax treatment, to a government health centre. And that is where the case is there. That's where the person's then counted as a case. So some of these numbers are really reflecting the first point of call, but to be a confirmed case, it has to be that they get the treatment, and that's where some of these numbers are. The other thing is in some countries, there's restrictions on what community-based volunteers can do. They may only be allowed to test or mobilise, and then they'll have to refer to the government services, or the government services come to points where people have been mobilised by the village and community workers, but they're counted then as as government sector clients. These are the sorts of people who are providing those services. In my top left-hand side, I don't know if you can see the pointer, that young woman there is the wife of a military person, and she provides services to people in the military areas along borders. The military do not like their clients to move, their soldiers to move out of the areas. So actually supporting an NGO, helping support workers within the military camps who are allowed to be there, actually allows services to be provided. The person in the middle, looks like a little bit of a more fixed facility. This is at a border post area. She provides services there and can help people navigate through the health system, and often hauls the government services in to provide the services she can't provide at that location. This older lady here, she is in the village. She was a village health volunteer, but now actually also was chosen. All of these people were chosen by their communities because they trusted them, had some leadership qualifications and a little bit of education, so that they felt that they could actually help provide services to them. And this woman, when we met with her, also talked about how she can mobilize transport and other things, really helped with the COVID vaccination for her community. So is able to mobilize a lot of other things, as well as being the malaria volunteer. These young men here are at a more mobile border location. So they actually move. As you see, it's not as fixed a facility, and they can actually move to where people start crossing borders or crossing to go into the forests, so that they actually are where the people are. And then the others here show you some others providing services in the community, in community facilities or homes, sitting within a plantation and in a community providing services, and these young women providing also on a major transport route in and out of forested areas and border areas. And this young man, ready for all sorts of weather, carrying what he required to be able to deliver services when called to go to people's homes if they're too sick or people are worried that they may have malaria. They're called various names in various countries and settings. They may be community malaria volunteers, community malaria workers, mobile malaria workers, Kato, where there's in the plantations where there's slash and burn malaria workers, but they all have around the same sort of range of activities that they're providing. And all of these that I've talked about are supported through civil society organisations, but are complemented and linked to the government services through supply chain and health information systems. So taking the lessons learnt about the really important role of community-based workers who can do testing, treating, mobilising, helping people navigate the system, as well as social and behavioural change communication, to complement government services, particularly in locations where government services cannot routinely reach, may not know the languages, may not be accepted because they are not of that ethnicity, may not be able to go because these are unofficial, and that's difficult for government people to serve unofficial migrants and mobile populations, or people who may be doing what is defined as illegal activities in those locations. So it's really critical if you want to reach all the population to eradicate malaria, and then you need to use community-based workers and services, and support it well with supervision, training, and link to government facilities. One of the things we're just starting to do now in the elimination setting is community-led monitoring in the Greater Mekong. We are drawing upon the work that was done by civil society for malaria elimination, CS for Me. Their work really was for high burden settings and a lot of the African type programs. There are differences in those compared to what we're doing in the Greater Mekong and in elimination settings. I'll mention that in a minute. The Greater Mekong has different drugs, different vectors, different mosquitoes, where they bite, who they bite, when they bite, than the dominant ones in Africa. When you come towards elimination, the amount of money that's available to do things like community-led monitoring has greatly reduced. We've seen a major reduction in the budgets overall from the Global Fund, but particularly for many of these community-based activities. So we need a model of CLM that is not as resource intensive as some of the models that have been developed in other settings and for other diseases. There's some limited capacity to be able to do this, so we need to build that capacity up. And we also need to build this up, keeping in mind that CLM is a good thing to do beyond a global fund granting round. So we need to be able to develop this so it can be transitioned after the global fund money is finished, so that community voices remain a major part of trying to look after the quality, access and coverage of malaria services in the region. I mentioned I'd briefly talk about what some of the differences are in elimination versus control. So in elimination, we're often, as I showed you, looking at those last kilometre or last mile populations. So very different populations who I've talked about. What the concerns are or risks for community are often these are very vulnerable populations, often stigmatised, may be seen as illegal and unreached by other services and social services, have poor health and other literacy, and cultural safety issues around how services may be being provided. So these may be things that communities want involved in their CLM. We do active case detection and then investigation of cases. You're trying to find every person who may have malaria or maybe has a parasite in their blood, even if they don't have symptoms. And so it runs the risk of maybe over vigorous investigation of people who are what is called an index case from an epidemiological point of view. Voluntary consent may be harder to maintain in those settings, as well as privacy and dignity of the individual or their families. Often we use community level mass drug administration, but in any infectious disease where you use mass drug administration, there's concerns around consent, provision of adequate information for people to make choices, and access to the MDA and therefore the benefits by mobile populations. We have to support adherence for the longer duration treatments, not as long as TB and HIV treatment, but still it's a concern trying to support people for 7 or 14-day treatments, and that they have to actually travel for a particular screening test. I won't go into the detail of that for P-Vivax, but there's a test that isn't available in a format for community-based testing. And so they may drop out of services, or when they get there, the services may not be open or may not be have supplies. We've mentioned the re-establishment of malaria, and so there will be investigation of any case of malaria that recurs, even if, so there's a concern about how is this done, how respectfully is it done, and what does it mean in making the community the eyes and ears surveillance? What tensions might that create? What power dynamics might be in that? In looking at integration of services, so there's a lot of push now in sustainability and transition. Can we integrate malaria services into other primary healthcare services? Can we add other health activities into malaria? The questions there from a community perspective may be, well, if we integrate, what might be lost? Are there going to be issues around access or quality of services or poor coverage for some things as we add more onto the backs of a primary healthcare service? And one of the last ones is, now that malaria becomes a less frequent, not as common disease as others, or has disappeared, it may be that malaria is forgotten, so not suspected, not treated, and people will die. And in all of these, to make sure that we have a gender equity, disability and social inclusiveness lens. So to finish, these are some of the areas that we feel could be supported in the Greater Mekong: support for implementing CLM, support for the GEDSI analysis in the Greater Mekong subregion, capacity development on quite segmented, so very specific for all those different populations, social and behavioural change communication, support to help integrate malaria into other health and development, CSO and CBO activities in the Greater Mekong, building up community-based surveillance systems to be able to help identify and prevent re-establishment of malaria, and capacity strengthening to identify the risks for and the impact of climate change on malaria, because malaria is one of the identified specific climate-sensitive diseases. I also would just like to note, I know there's colleagues on the call who work in the 3 malaria-specific countries, Papua New Guinea, Solomon Islands, and Vanuatu. They have potentially needs, and I do encourage them also to think about what could be supported through this learning hub moving forward. Thank you very much.
Thank you, Maxine, for your presentation. So we have one question in the chat box from Mohammed. Mohammed, do you want to ask your question directly, or should I read the comment in the chat box?
Hi, I'm sorry, I'm not be able to switch on my camera, but thank you so much for this informational hearing. I was so very impressed. I belong to the field of molecular biology, and rapid disease diagnosis and testing is one of my specialties. I really would like to know a factor weight here. You mentioned about mobile health and people going and working with communities. My question really was around that, but since you already answered that, I would like to know if you faced any form of resistance from these communities in terms of the belief in the healthcare system itself. We quite often find that in rural spaces with limited access to health services, there's a lot of taboo in these systems or communities to believe into the idea of vaccinations or medications themselves. So just want to know if you have faced any such kind of resistance from these communities.
Thank you. Some really good questions there. Firstly, just the one you put in the box. So yes, we do use rapid tests. That's been the real revolution for being able to increase access to services, is having community-based volunteers be able to do rapid testing and some, hopefully, treating, although some governments have not allowed the full package to be done. But yes, those are happening. And again, also sharing data by mobile phones or whatever into the government system. So technology is actually helping a lot to be able to keep reaching populations that often are neglected. As far as thinking about acceptance, I mean, one of the reasons the civil society-based workers are really important in these communities that have been neglected and are the last kilometre of malaria transmission is that these are people from their communities, they speak their language, they are the same ethnicity, many of them are also migrants themselves and cross the borders, they work in the fields, in the plantations with them, so they are of those populations. They also then help navigate people into the government system, and one of the things that's happened is some small incentives for these people to actually pop them on their motorbike or travel with them to the health facility so that they can increase the safety, if you like, of these people to be able to access services. So if you want to work with these populations, you really do need to work with them and have people who they trust, people who they know speak their language, understand their cultures, and can work with them to try to overcome some of those, and also some of that concern about the government services.
Thanks, Maxine, for answering this question. Any other question from the floor? While we are having Prof. Maxine here, so
Hi,
John.
Ika.
Yeah, Chinmay.
Yeah, I don't have a question, but I just have a comment.
Yeah.
Maxine, thank you so much for the presentation. And, as we discussed before as well, and today also, what I see in terms of next steps, that there is a lot of gaps when I was seeing your presentation, where there are opportunities available, but somehow we are not able to reach out to those opportunities. And I'll need further your support in in identifying countries where we can reach out to them personally and talk about short-term technical assistance.
Sure.
Because like this is what I'm seeing as well after this webinar. The next step for me is to reach out to countries and talk about technical assistance with them and try to get benefits from the opportunity which is already available. But thank you so much once again for your presentation.
Thank you. And Jinmi, I think also an important thing is many of these populations we're talking about also have at least TB and probably HIV issue. So can we also work together and maybe with some TA support to integrate malaria into the services for those populations so that we are reaching as many people as we can and they have the right to services that they should have?
Yeah. Thank you so much. That will be the great next step for us.
Thanks, Maxine. Then I will move to Hari Prabowo to give the closing remarks since we are at the end of the session. Hari, over to you.
Thank you, Ika. Hello, everybody. I'm Hari Prabowo, a program manager at Asia Pacific Network of People with HIV, or APM+. As we finish today's webinar, I want to thank you all of our speakers and participants attending the second virtual learning session of the Asia Pacific Learning Hub by the 7 Alliance. Your hard work and insight have made this event truly valuable. Zero malaria, that's what Sri mentioned earlier. It's clear that eliminating malaria takes the dedication of everyone, from community members and civil society to government and global partners. After listening to Maxine and look at her quote for the promotional of today's learning session, now I know that reach malaria elimination needs the hard work and commitments from the community, civil society, government, global partners, basically across all sectors. To achieve and sustain elimination, it needs to ensure that everyone deserves quality health care. Frankly, I also excited when I heard in malaria program, they're also rolling out the CLM. It shows the same commonality amongst community and civil society affected by three diseases, TB, malaria, and HIV. Our goal today was to empower malaria civil society and community representatives in the Asia-Pacific regions. We also aim to increase awareness about malaria community initiative, understand the challenges, and support each other with available resources. I believe we have made great progress in achieving these goals. Eliminating three diseases, malaria, HIV, and TB, requires all of us to work together. Whether we are from the community of civil society, we need to join force through partnership collaboration. By working together, we can ensure everyone gets the service they need. This united effort is essential for achieving and sustaining elimination. Community engagement is a key to our success. We have seen how community-led initiatives can drive significant progress. However, we also know there are challenges ahead. By working together, sharing knowledge, and using the support from the Asia Pacific Regional Learning Hub, we can overcome this obstacle. The technical assistance from the Global Fund and other donors is valuable resources. These resources can help us address gaps, build capacity, and implement effective strategies. I encourage all malaria communities and civil society organizations to apply for this assistance and take advantage of the support available. In conclusion, today's webinar has shown our collective strength and determination. Let us take forward the insight and connection we have gained today to strengthen our effort. Together, we can make sure all communities get the service they need and work towards a malaria-free future. Thank you again for participation, and let's continue work together, build strong partnership, and make lasting impact. Like I always say, together we can make difference. Thank you. Go back to you, Ika.
Thank you so much, Hari, for your strong message. I definitely agree that we need to work together to end the three diseases in our region. So after this webinar, we hope that we can have more collaborative work. And also, please feel free to reach out to Chinmay, Hari, and myself if you need any support to the technical assistant. Once again, thank you so much for joining our webinar today, and see you in the next webinar.
Thank you. Bye.
Bye.
Bye.